Hello, everybody, and welcome to another TNL Thursday Night Live. We're so excited to have everybody here with us today. We have a little bit of a local professional close to me today, so I'm super excited to have him here. We are live on Facebook just to give you guys a little bit of a teaser as we're recording this live. If you're watching this on a Thursday, March 19th should be the day that we're airing this. However, if you're a member, you get to watch these early. So if you're not a member yet, please run and join us. Alrighty, so today's speaker presenting Dr. Tyler Rathburn, known as Dr. Tyler. He completed his DMD and orthodontic certificate at the Medical College of Georgia in 2015. He practices at Atlanta Orthodontic Specialists alongside his parents, Dr. Michael Stewart and Dr. Melisa Rathburn, and works with a multidisciplinary orthodontic team. He began lecturing in 2017 and has served as resident faculty with CDOCS and SPEAR Education. His interests include airway-focused orthodontics, CBCT analysis, interdisciplinary treatment planning, and technology-driven practice efficiency. Dr. Tyler is a diplomate of the American Board of Orthodontics and currently serves as president of the Georgia Association of Orthodontics. It is such an honor to have you here on Airway Circle stage today. The topic is Maxillary Transverse Deficiency Syndrome, the case of early expansion. I absolutely love this title, and I really believe that we should start calling it a syndrome. Not enough people are, even know that it's a big problem if you're too narrow. So say hello to everybody. The floor is
Yes.
yours.
Well, thank you for having me, and I appreciate being here. I'm going to go ahead and share my screen. It's an honor to be with you guys, and appreciate the invite.
Thank you. And where are
Being
you guys
here.
located in Atlanta?
We have a few offices in the area:
Okay.
Sandy Springs, Buckhead, Virginia Highlands, and College Park. So we have a group practice. My parents, actually, my mom, my stepfather, have retired. My mom retired literally, I guess, a week ago. It was the end of December
Oh my
31st of
goodness.
last year. So she's going to fill in for us when we're out of town. But myself and Dr. Chris Brady, Dr. Kent Starling, Dr. Marisa Moore. So we're kind of about the city, but I've been in Sandy Springs, Buckhead probably the longest,
Mhm.
but Highlands for a while. And I'm actually today down in College Park near Woodward Academy. So we have an office right across the street from Woodward, and it's been a lot of fun. So
That's
again, I
amazing.
appreciate you having me. And I took the title of this, actually. I stole this language from another orthodontist named Dr. McNamara, who is I would say, a much more famous orthodontist than me, that I learned from. Why I'm interested in this really is, I'm an orthodontist by trade, and I think many of us probably know that orthodontics and airway, there's a lot of controversy at the moment amongst different practitioners about what airway means and how you address it, and how you treat and your practice philosophy and such. A very wide range from people who are very, very proactive to those who thinks that all of this is as a hoax, as I've heard described online, and then many people who are in the middle or who are unsure about um, what it is that people are talking about. So my goal has been to try to bridge that gap, and I actually think it's not nearly as complicated as we make it sometimes.
Mhm.
Many of the things that people like Dr. McNamara were talking about for years in terms of maxillary transverse deficiency, which he related mostly to things like crowding and a lack of space, or class twos, class threes. Those are airway problems, and they're the same problem. And so, if we just figure out a better way to identify those problems, we're all going to be treating both this and airway, because it's all the same thing. So it's an attempt, I think, to try to bridge the gap, maybe for some skeptical people out there who
Mhm.
may not know much about it, where it's I think made a little more simple. And you can think about it from the dental perspective or the airway perspective, but ultimately the treatment plan is going to end up being typically the same with expansion, because that's what we're really after. So we'll talk a little bit about that, and I hope it's useful for you guys. So with that, I'll go forward. You did a great job introducing me. I don't have to do that.
Thank you.
Currently, though, I'm with SPEAR Education. That's where I am now, I do some courses on I do a lot of restorative orthodontic treatment. I don't do the restorative part of it, obviously, but I teach a course there on ortho and restorative with aligners. And also Jeff Rouse is a big airway doctor and a big educator out there, has been at SPEAR. So I've taken his course and learned a lot personally from him as part of my journey. Through that, my kids, my wife Stephanie, my son Lincoln, daughter Charlotte, and wife Stephanie are what keeps me interested in doing all of this. It's a lot of fun. We're going on vacation next week, actually. This is our practice. So my mom, obviously, you can probably tell who that was in the middle. And then also in the front, Dr. Moore, and then from left to right, Dr. Starling, Dr. Brady, and myself in the back. And my
So,
stepfather, Dr. Stewart,
aw.
who is he's not, it looks like he's dead when I do this. He's not. He's very much alive and kicking, just in memoriam. He's retired and enjoying his retired life, but he used to be part of our headshot and isn't anymore. So
Well,
that's
whenever
our
you
practice.
whenever you said Dr. Brady, I was like, I think I know him. I've met him before.
Yeah,
I met
yeah,
him at
Chris
the
Brady.
Hinman years ago.
Yeah,
That
super
was
nice guy. His dad is an
like,
oral surgeon in town, Gordon Brady. He's been around. He took my wisdom teeth out many years ago, and we've known each other for a long time. And Dr. Moore joined us about 2 years ago now, and has done an awesome job, and is a great young and fun orthodontist. Cooler than I
super
am, I guess.
excited.
This is our office. I will make this brief because I know it's on the topic, but Sandy Springs, Howell Mill, Buckhead, Highlands, and College Park. So three full-time offices, two that are part-time, and it's a lot to manage, but it's a lot of fun, and it's been a joy to take care of. I work primarily mostly in Sandy Springs in the Howell Mill area. So again, I took the title of this topic because I think it's a familiar uh, verbiage that any orthodontist would know and would have studied back in residency, and I took it from Jim McNamara, who was an orthodontist at the University of Michigan, educator, wrote a lot of articles in the AJODO, did a lot of research as well. And it's it's a topic we're all familiar with, and he was a big advocate for expansion. In fact, he was the first, at least the first article that I remember reading about a properly designated intermolar width of 36 to 38. That was McNamara. And at the time in residency, you do a lot of measurements and you realize there's not a lot of people with that intermolar width. And so there's some people who obviously are acolytes of his, but there's others who say, well, because he likes expansion, his intermolar width is higher than most people. And so there's some skepticism in there, but he wrote a lot of the early articles on the need for more and more palatal expansion on our patients, especially in phase one, and talked a lot about how occlusions tend to improve over time with expansion. So he talked about spontaneous class 2 improvements with expansion and some improvements in class 3 patients with expansion as well, both of which I can say I've seen a lot of clinically, because again, this is more than just treating the teeth and the arch. And of course, one of the quickest, easiest ways to do a intermolar width measurement is 36 millimeters is the width of a cotton roll. And so you can put the cotton roll between the first molars and you can kind of get a sense of what that is. And that's measured again from the lingual aspect of the molars in terms of the width there. But I actually don't like this measurement at all, really, because I want to show you how I think about this. As an orthodontist, I can move teeth. I can move teeth out and back in. I can tip them out. I can tip them in. I can move them bodily left and right. But what I really, really care more about than the teeth is actually where the jaws are. So I really don't use intermolar width at all, hardly in my practice. But I will show you what I use. And the reason I don't is to get some background, one of the things where all residents in ortho are taught is what's called the 6 keys of occlusion. And it's a paper written by Larry Andrews. It's written in the late 70s, I believe. And there are 6 keys for every orthodontist to go through on their patients. Okay, and this is how we were judged, board standards in our practices, in our residency when we took cases to the board. And the third of those keys is what's called proper crown inclination or facial lingual positioning of teeth. So anterior teeth are supposed to have a slight positive torque, but posterior teeth are supposed to be upright. And upright or with a very slight lingual inclination. The way that we used to get judged on this is there was a little instrument. I can't describe it, but there's a little instrument that the board examiners used to use, and they would slide this kind of like a ruler almost across your occlusal plane. And if there's a little step, and if that step between your buccal and lingual cusp was over a millimeter, you used to get a point off of your case, and it was 27 points and you failed. So essentially, the third key was having posterior teeth upright with a slight or with a very, very slight lingual inclination. But what that really implies, though, has a lot more to do with where the bone is. We want teeth that are centered and upright over the bone. Okay. So teeth that are centered and upright, centered in the maxilla and the mandible, with the teeth well intercuspated. And so when this patient functions in an ideal scenario like this, you have bones supporting the teeth on either side, buccal and lingual. When they eat, chew, function, all those things, these teeth are going to be well supported. But what's really important about this to understand is that this requires the maxilla and mandible to be a certain size and to have a certain relationship between one another. So if your upper teeth, for example, are supposed to fit outside of your lower teeth, then your maxilla has to be wider than your mandible at that same position. If it's not, then we run the risk of running these teeth through bone. And the reason I don't like intermolar width is because intermolar width does not account for the tipping of teeth. So if teeth are buccally flared or buccally inclined, then you tend to have a very large intermolar width. If teeth are lingually inclined, you tend to have a very limited intermolar width. But it doesn't show you at all where the maxilla is in relation to the mandible. It just shows you how the teeth are inclined. Now, it's not a bad relationship, but there are better ones. And so what I want people to get used to looking for, though, especially in terms of airway and things like that, are patients like this. This is what's called a compensated discrepancy. And one, as a resident, you're taught to do palatal expanders, or well, for example, one of the phase 1 treatments that's pretty much a no-brainer standard of care type in orthodontics is if you have a patient with a posterior crossbite, you do a palatal expander. And anterior or posterior crossbites are phase 1 treatment goals. Okay, but this image is a patient who has a maxillary transverse deficiency without a posterior crossbite. Okay, they also have a fairly wide intermolar width because the teeth are overly inclined to the buccal. Okay, but what we really want is this. We really want teeth that are centered and upright, center in the maxilla, center in the mandible, and well related to one another, sitting straight up and down. And to go from here to here requires not just the teeth to change, but that entire green box representing the maxilla on the upper to change. The only way that happens is with palatal expansion. Okay? And many patients, as I'm hoping to show here later, patients exhibiting airway concerns have this scenario all the time. They don't always have posterior crossbites. And so a lot of times they go undertreated or under-recognized. And then again, another question just to ask your patients, if this is something you're new to, is just, are they having any breathing, snoring, sleep concerns, ENT-related problems? And almost always a patient with a scenario like this will give you something in that regard. Oh, they had adenoids out when they were younger, or they've had tubes, or they had this, they were sleeping better, now it's coming back. All of these things. And they're all related. They're all related to this maxillary transverse deficiency syndrome, as Dr. McNamara would put it. And when you do a palatal expander to get to A from B, this is essentially what you're doing. So you put a palatal expander in, you typically overexpand as much as you possibly can. You can then, on the top right photo, you can then upright the lower posterior teeth, either by just letting it happen passively, or most often what we'll do is put a lower expander on, or you can do lower aligners or lower braces to upright the lower posterior teeth. That allows you a better reference point for your maxillary expansion. Then you allow the upper molars to relapse once the expander comes out. And then at the end of the day, you end up with a better scenario for your teeth. You also end up with a better scenario for your airway, because it's all a part of the same problem. So expansion looks like this. This is what happens when you do a palatal expander. But just because the patient doesn't start off at a crossbite doesn't mean that the relationship is improper. Okay. And there is, I think now, and this is just a sample of 5 articles, I'm sure you could probably find 20 of them now, talking about the expansion of the maxilla causing expansion in your airway volume. And quite frankly, I think it's a little ridiculous we even have to ask for this research. I mean, if we just know anatomy, your maxilla, the floor, the roof of your mouth and the floor of your nose are the same thing. And so if you make the roof of your mouth bigger, you make the floor of your nose bigger. And if you know geometry, that has to make things larger. So it's going to, and it's been proven now by multiple studies, seemingly over and over again. People who are detractors of all this typically say the studies aren't well done, or they're not enough samples, or yes, it changes volume, but it doesn't matter. Those are all, I think people have their own prejudices toward different treatments, and that's fine. But what again I'm hoping to do is to show that this is all the same thing. Now, why is the maxilla so small for modern humans? And there's a lot of different reasons. Actually, it's not just airway, but it is also a lot of airway. So one of the biggest things I say on a macro level, if we really zoom out from a top-down perspective, is that we just don't use our jaws like we used to. Ever since human beings have been able to cook food and do agriculture, all of the anthropological studies show that our jaws have gotten smaller. And you can see this pretty quickly in the anthropological literature, because you can see, and you can even see it on skulls of Neanderthals. They all have the wisdom teeth are all in. They have straight teeth. They're all worn flat, and they have huge jaws. I would not have a jaw back then because the jaws were bigger, because we used them a lot more. We had to. But once we start cooking and things, we don't have to. And so this is the epigenetic factors of use plus genetics is what drives a lot of our development. Tongue positioning and posture, which of course is related to airway as well. The tongue develops the palate. If the tongue cannot elevate to the palate, or if it's restricted in some way, or if they're mouth breathing and the tongue posture is low, those are all reflections of usually what will end up as a narrow maxilla. Restrictions, so tongue ties, habits are, of course, a huge topic as well. I'm not sure when pacifiers were invented, but I certainly don't think they were in use hundreds of years ago. But when you go home from the hospital, you get like a whole bunch of those passies, and some kids use them and some kids hate them. My daughter loved hers. My son did not ever take one. But those as non-nutritive sucking habits, especially thumbs, can be a huge developmental constrictor on the palate. Breastfeeding is important, right? We know the importance of that. The infant's tongue, pressing and developing their palate. And as a culture, we just don't breastfeed nearly as long as we used to. And it's quite frankly, my wife had a very hard time with it for both of our kids. So it's not like a given. But in other parts of the world where that's more and more common for longer periods of time, you actually see less dental issues because things get bigger. And then lastly, are genetics. Now, all of these are many of them are airway issues as well. Okay, so mouth breathing, nasal breathing, and tongue posture, those kind of things. It's all related. So it's somewhat of a chicken and the egg scenario to a certain degree, although it's always going to be a bit of a genetic versus environment, but the environment has a lot more to do with it than people want to assume. In residency, we're taught a lot about it's kind of just genetics. You kind of assume that people just get to where they get, and then you fix it from there. And I think that's I've reconfigured my thinking on that for sure. Obviously, tongue posture and usage is important in terms of the passive development of your arch. To have your arch develop normally, you need the tongue to be able to elevate and develop and press and develop the palate. It just makes the most sense. Now, what I like to use in my practice and routinely in all of my patients is something called the Penn CBCT transverse analysis. This is not something I learned in residency. In fact, something I learned while teaching at CDOCS from a few faculty who had developed it, who were working at Penn. Okay. Another thing to understand about orthodontists in general is we are taught really, really well in two dimensions. We're taught AP, so front to back, so class 2, 1, 2s, and 3s, and we're taught vertical, so short face like myself or long face development, because that's what cephs show. Okay, cephalometrics is a huge part of orthodontics, but cephalometrics is two-dimensional. And as a profession, we have struggled to jump the gap from 2D to 3D. We have a ton of analyses for cephs. We have, I would say, it seems like hundreds of analyses for cephs. Um, there are some big ones, obviously, that we all learn, but we really have very few for CBCTs. In fact, the routine use of CBCTs in orthodontics is another controversial term, or excuse me, controversial topic amongst some educators, people who think it's overused. I would argue that we just don't have a lot of analyses for them, except that we do, we just don't know them. Okay, this is one of the easiest ones to use. If you take this slice of your CBCT and you are going to define kind of where your maxilla and mandible are. You can use the mucogingival junction as a good guideline intraorally, but if you look on a CBCT, that area is roughly correlated with the maxillary molar furcation on the upper and lower. And so what we really do is we find the maxillary molar furcation where that furcation you start seeing the roots divide. You can find the furcation, and we can make a measurement from the buccal aspect of the cortical bone on the upper arch, on the inner aspect of it, and we get a number. Okay. And it's not actually important what the number is. Okay. Because what we're going to do is then relate that to the mandible. Okay. So we're going to find a measurement for the maxilla. Then we're going to repeat the same steps for the mandible. We're going to go down to the slice. We're going to scroll down. We're going to find the molar furcation separation in the mandible. And we're going to make another measurement on the inner cortex to inner cortex. Okay. And we're going to find another number. And that number, in an ideal scenario, that number should be about 5 millimeters shorter or less than the maxilla. Okay. We want the maxilla to be bigger than the mandible. If I am an orthodontist, then I'm not even focusing on airway for a second. Let's just think about teeth. If I want the upper teeth to be wider than the lower teeth, I have to make sure that the maxilla is wide enough to accommodate those teeth, and that means the maxilla has to be wider than the mandible. Okay. And what's funny about this is it's amazing how many times you can do this measurement on people who've never been treated, who have a good relationship, and the number is almost always 5 or within a half a millimeter on either side of it. But the whole principle is that this allows you to position teeth better. What it also does is it makes sure that your maxilla matches the mandible. And this is a great tool to use on patients who have those compensated discrepancies, who may not be in a crossbite, but are exhibiting transverse problems. And then, of course, airway comes into discussion because it's all the same problem. So if patient's asking, well, I don't have a crossbite, why do I need an expander? Because that's sometimes what I come across. Because again, I'm the orthodontist, so sometimes I'm seeing it on the back end. You can relate that to a deeper discussion about what the patient is doing. The other thing that's great about this analysis is it's a relationship analysis. Okay. And part of the thinking here is that the mandible has no sutures. Okay. So the mandible typically develops by the tongue being there. So you'll have patients with really big tongues, they have really broad mandibles. People with very smaller tongues or restricted tongues tend to have very narrow mandibles. The maxilla has to be related to that because at the end of the day, unless we're doing, a symphyseal distraction surgery to widen the mandible, which is extremely rare, the maxilla can't go beyond the mandible. Otherwise, we don't have an arch to occlude on. And so what I use this for is, if someone's exhibiting airway problems, how helpful will expansion be? Okay. If I have somebody with a well-related maxilla in the transverse dimension, the numbers match, and they're exhibiting airway problems, the constricture may be somewhere else. It may be a front to back relationship. It could be the maxilla-mandible are set too far lingually or too far posterior in the face. It could be something as simple as a deviated septum that hasn't been addressed or large adenoids. Now, what the reality of it is with kids, things like large adenoids and stuff will develop a narrow maxilla. So you get those problems seem to run in tandem. But for adults, it's very useful to see whether or not something like a MARPE is the correct call for a patient exhibiting airway concerns. And many times it is, and sometimes it could be more of an MMA advancement, or there could be ENT referrals for adenoids, and not on adults, but for deviated septums, or for bad allergies. There's obviously tons of reasons there could be problems. Okay. And I would say the reality of it is the numbers are not as infinite as we think. I mean, I would say on the high end, I'm seeing maxillas 63 millimeters, maybe 65, on the low end, 49. It's a 12 to 13 millimeter range. Okay. But the problem is the teeth fool us a lot of times because the teeth live inside there and we look at it all the time. Now, we don't always have a CBCT, right? So if you don't have a CBCT, which many don't, which is fine, you can use something like this from the frontal perspective. You can now this one's a little more obvious because there is a crossbite on the left side, but you can go to the first molar position from this frontal aspect here, this frontal picture, and you can drop a line either in your mind's eye or on a photo if you take photos from the at the mucogingival junction around the first molar, and you can drop that line straight down. Okay, and that line is essentially equivalent to the CBCT measurement that we're looking for, right? The molar furcation. Well, that should sit at or beyond the first molar at the same position. If it doesn't, then your teeth are fooling you and you need an expander. Okay. If that means the maxilla is too narrow compared to the mandible. And what I have found in my early practice and in looking at cases that have been presented, particularly extraction cases, I have noticed many transverse deficiencies camouflaged through extractions. I've also found many occlusal issues, like for example, this patient exhibiting a slight of anterior open bite, which is again could be related to airway and also the constriction. These are all we have to think in all three dimensions. And so, traditionally I would think about this in terms of two dimensions, right? It's a vertical, the open bite, got to work about the open bite, but it's really more of a transverse problem. But the mucogingival junction is a good proxy for that. And then you can take the teeth and you can draw kind of a line down the long axis and you can see how the teeth are inclined. Okay, so in this case, this is what we see most commonly, the upper teeth are nice and upright. They're where they're supposed to be, but all the lower teeth are lingually inclined. You can think about it like teeth don't really want to be in the wrong position, and a lot of times they camouflage themselves so as to not be in a crossbite. But if you were to put them where they're supposed to be, they would be in the wrong position. And all of these are examples of compensated discrepancies. Okay, all of these pictures are pictures of patients who have a maxillary transverse deficiency syndrome. They have a maxilla which is too narrow relative to their mandible. Some of their occlusions look better than others, but at the end of the day, all of these patients, for best treatment, in my opinion, would need a palatal expander. Many of them also exhibit airway problems. There's a few who don't, but many who do. Because again, the maxilla being narrow, it's harder to breathe through your nose. And again, that it could be, it's a bit of a chicken and the egg scenario, but if you have to break the cycle somewhere, it makes the most sense to expand the maxilla. So we do a lot of expansion. We do a lot of early expansion. If someone's having airway problems, I have no problems putting a patient into an expander if they can tolerate it, around age 4.5 to 5 or 6 or whatever. Traditionally, orthodontists want to see patients around age of 7. Sometimes that can be too late. Many times that's okay. It just depends upon the scenario and the patient, and a lot of times on the symptoms that they're exhibiting. Now, as an orthodontist, I'm not doing, that's about as early as I will see patients just on the nature of my profession. So I just don't see them earlier than that in a referral basis and stuff. But if you look at all of these patients, right, if you take them first molar and you drop it straight down, they're all sitting inside the mandible. So again, I'm not even looking at the teeth. The teeth I hate to say the teeth are the least important part, but they are the least important part. I can move the teeth wherever I want them if I'm assured that the skeletal bases are correct. If there's any dentists listening to the podcast or to the stream, I would say in SPEAR Education, we talk about the wax rim concept. If you were to design a denture, you have to make sure the wax rim is wide enough to accommodate the teeth. And it's the same concept in orthodontics. We have to make sure the maxilla is wide enough to accommodate the teeth. So when you set teeth in a denture, you define the wax rim not based upon where the maxilla is. You define the wax rim based upon the patient's smile and the wax rim and how broad you want their smile to be. Right. And so that's the same concept applied orthodontically. It means you have to make sure the maxilla is sitting outside the mandible. Okay. I show this case. I have a couple cases to show. Okay. And this is a great case because this is just like anything, whenever you go to like a CE event, it seems like you come back from that event and the only thing you see everything that the person was talking about. So when I took the airway course with Jeff Rouse, I had kind of heard a lot of the information before, but he did a great job of, I think, crystallizing it all into a cohesive course for both kids and adults. So adult airway problems, and then the developmental problems with kids. And this stuff is in our literature. I mean, adenoid facies has been reported in orthodontics for a very, very long time. It's the treatment planning and the concept about how to go from a patient exhibiting airway problems to someone who's not, which seems to be the hang up. And so my whole goal on the maxillary, transverse deficiency syndrome and the analysis of it, which is not something we're taught in residency, is to bridge that gap because it's the same. If you didn't want to think about the airway, you could think about the teeth and the jaw and making sure the skeletal bases are correct, and it would be the same solution. At least that's my hope. It's been very helpful for me, at least. All right. So, and these patients come in, they're identical twin boys, or they were identical twin boys, I should say. Okay. They look different. Why do they look different? Well, the kiddo on the left of the screen, well, both of them, I should say, were exhibiting some airway concerns, bad enough for mom to go to the ENT. They were having a hard time sleeping. They were really bad snorers, and they were grinding. Okay. She took them both to the ENT, to an ENT that I like and work with and respect. In ENTs, many of them are very conservative, and I can respect that. I'm not going to overrule my local ENT, but the patient on the left, his symptoms were really, really bad. I guess they were a little bit worse than his brother. And so on that patient, he elected to take out adenoids and tonsils. The patient on the right, his symptoms were there, but they weren't nearly as bad, and they took a watch and wait approach. Okay. You can see automatically from the facial photo here the difference in their facial structure already. The patient on the right has a much longer face, shows more of his teeth, more of his maxilla, because you're getting that downward and backward growth of downward growth of your maxilla and then backward rotation of your mandible. You can see that also really, really well in the profile. Okay. The profiles are different. The patient on the left is growing a little more normally. He's still a bit class 2. The patient on the right is growing much more vertical and much more class 2. From a purely orthodontic perspective, the patient on the right is much harder to treat. But also, if you see a patient like that, you should be thinking about their airway, or lack thereof, I should say. Okay. Now, what's interesting is both of these kids had narrow maxillas. Okay. So if we try to relate these two concepts, here's the kid who had his adenoids and tonsils taken out. All right. He comes in, and right away, when I see him, it's a pretty obvious, I would say for most orthodontists, quite frankly, it's a fairly obvious expansion case. He's got a crossbite on the left side. He's wearing his teeth down flat because there's no overjet, and he's grinding like crazy. And so again, this is I would say a tailor-made palatal expander case. Now, if you saw a patient like this who didn't know they had any problems, then you'd want to talk about, airway and expansion. But that conversation was very easy to have with them because they already had that in the past, right? And so you can look and see, he's missing a couple second premolars. But here's the CBCT analysis. Okay. Now, again, his airway looks fairly decent here because he's had adenoids and tonsils totally removed. But if you look at maxilla to mandible, the numbers are even. The numbers should be 5 millimeters wider than the mandible. So what this shows me is that this maxilla is 5 millimeters too narrow from where it is supposed to have been. Okay. So he's going to get a palatal expander. Now, his brother, interestingly enough, okay, if you look at his dentition initially does not look as bad, right? It looks a lot more normal. Now, he has wear on his primary teeth and he's grinding. So again, that would prompt an airway discussion if you didn't already know the history here. And so, but for orthodontist, you've got no posterior crossbite. He's got some mild crowding. So do you do anything, right? Is this a transverse problem or no? So again, ignore the teeth and turn to the CBCT. He's also missing a few more teeth than his brother. But look at this. Okay. So his maxilla is 56, his mandible is 54. So his maxillary discrepancy was actually less. It's only 3 millimeters. But you can see, as I've highlighted in the box there, some relatively large soft tissue, some adenoids in there that are blocking the entire blocking the entire airway. But what's interesting is that his maxilla was actually not as narrow as his brother's. So my thinking on this was that maybe his maxilla being ever so slightly wider was why his symptoms were a little bit less. The reality of it is they both need expanders, and this patient is now going back to see the ENT to have his adenoids out. Okay. Um, Here's three siblings. Okay. And that my point here is it's not just, it's not just genetic. And because that's what we're taught a lot of. And, I remember hearing in residency, you got good growers and bad growers. And, and it's true, you do have families of the same problem, but there are environmental components which you can intervene at. And if you intervene too late, this can be what happens. Okay. Here are three sisters. They're not twins, or triplets, I should say. They're not triplets. Oldest, or youngest to oldest, from left to right. Okay. Does anyone want to guess which one is the mouth breather of the bunch? Okay, so obviously the at rest, the patient on the far left is unable to seal her lips at rest. And also, if you look at her facial photo, how much gummier her smile. Now, the patient in the middle also has a gummy smile, but she has more of a little bit more of an altered passive eruption element to it. But the one on the left, her maxilla is just hanging out of her mouth, which is a tailor-made sign for someone who's mouth breathing, as is the inability to seal your lips at rest. Okay, now um, the the cephs on these patients are also informative. Okay. The patient on the far right has a very, very brachyfacial short face. The one in the middle has a little bit more of a normal face, maybe slightly brachycephalic myself. The patient on the left, though, has a very, very, very vertical facial pattern, which is unlike her two sisters. Okay. Her other sisters have a kind of a shorter square jaw, and she has a much longer lower face. That's another sign that airway has been a problem for her long term. Now, this is an issue. I think this one was caught too late. Okay. This patient is 9, I think, when she showed up to see me. Okay. Um, and here's why. Here's why it was caught so late. Here's her arch. Okay. She has some crowding. It's not extreme. I've seen worse. She doesn't have any cross bites either. The left buckle is not the best photo. The center photo is a little bit better. Okay. And she has some crowding. Usually the sign of these laterals flaring out is the sign that the canines are crowded. Again, that's because of a maxillary deficiency. If you used intermolar width on her, you would be fooled. Okay, because her intermolar width is over 40 millimeters. In fact, I think it was 41 millimeters, 42. Again, I don't care about that at all. What I want to know is maxilla to mandible. Her maxilla is 60, almost 61 millimeters. That's significantly bigger than both of those two boys I just showed you. Okay, but her mandible is also bigger. Mandible's 60 millimeters. So she's got a deficiency. That's as simple as it gets. She also happens to have huge adenoids. Okay, so again, all running in the same family. Now, even if you weren't savvy on airway at all, and you only wanted to think about the teeth, because for whatever reason, you could just do this. Maxilla is this, mandible is this. The maxilla needs to be bigger, and you can make it bigger. So the intermolar width to me has almost, I wouldn't say no bearing. It's just, it's not, it's, there are better ways to do it. And what's important to understand is where the maxilla sits to the mandible. And this is why it's also CBCTs are so important for my practice. I wouldn't be able to practice. I wouldn't want to practice without them, because I feel like I would do a worse job. I can guarantee you that, though, in my residency and probably in my early days in practice, this patient would not have been treated for phase one. Or we may have taken out a lot of times what we'll do is take out primary canines, right? Let the canines come in, and then, maybe someone's concerned about protrusion, so you take out teeth, right? You wouldn't do that, because it's not that. That's not the problem. Those are just band-aids on the problem. The problem is that she's been mouth breathing forever. She's got a narrow maxilla and huge adenoids. So for her, I did an upper and lower arch expander. I use a mini Hyrax on this age. It's just a Hyrax with a smaller box, a lower E arch expander, some limited braces on the upper and lower, which is the least important part of it. To be honest with you, the braces are the least important part of it. Just the expansion is the most important. And she goes back to the ENT to have her adenoids out, and here she is after treatment, after post-palatal expansion. Okay, now for what in her future, because she's going to come back and see me when she's 12 or 13, what is there going to be left to do with her? Probably not a whole lot, because you've treated these problems earlier. The problem is this gumminess of her smile. You can't put that back in the box. So she's able to seal her lips now at rest. She can breathe through her nose, but her profile, the length of her face, the droop of her maxilla out of her face, that is a problem that you cannot put back in the box now because it's treated a little bit on the later side. Okay. So again, transverse is the first dimension to be set and stable. We know it as early as 6 or 7. In terms of the studies on growth, you get passive arch expansion up until about 6 or 7, and then very, very, very little expansion up until 14, like a millimeter. So pretty much as early as 6, we're going to know what the maxilla to mandible relationship is. And quite frankly, younger than that, we know at least 80 to 90% of it. So that's the first dimension that I always think in that dimension first. It's the very first one I think of. Okay. And of course, the case for early expansion is, well, if I'm going to do an expander, just from a practical aspect of it, is my expander going to work better on a patient who's a juvenile or an adolescent? Because that suture getting more and more interdigitated, it's much, much better to do an expander on a younger patient. And you don't have to work as hard. You can be more guaranteed of your success. You don't have to go super, super fast in terms of your expansion either. But you get a chance to do it well. You also get a chance to do it over again. So for example, if you have a patient who relapses, they come back at 12 or 13, you can then go back and expand more when they're 12. I've had many patients, I mean, not a ton, but I've had quite a few patients where we've done an expander, it looked good, it collapsed a little bit. Could be that maybe they had a tongue tie that we didn't recognize, or we didn't get the expansion that we thought we did, or they should have been doing myo or something like that, and they collapse. Well, you can expand again when they're 12 if you need to. But once you start hitting 14, 15, I get a lot more concerned about my expander actually doing what it's supposed to do and moving the suture and not the teeth. Okay, you'll always move the teeth, but you won't always move the jaw. So the controversy in orthodontics is, well, do we expand just for airway purposes? Okay, well, someone's exhibiting an airway concern. Do we watch and wait or do we expand? Obviously, my answer is to expand, but I can justify that however I want, right? Because not however I want, because they're two sides of the same coin. Maxillary transverse deficiency and airway problems are almost always correlated. If they're not, then expansion is not going to be helpful. But I would say most of the time, I would say maybe 9 times out of 10, they are. And it's one of the first places that you see it. Okay. This is what we want to focus on. These patients are the ones who go undertreated because they're not in crossbite. Okay. I want to show you the importance of that. Here is a patient who is an obvious expander case. Any orthodontist in the country would probably treat this patient with an expander because they have a full crossbite on one side with a functional shift. Okay. Happens to have a fairly decently sized tongue tie too, if you want to know why that developed that way. All right. And so look at his CBCT. Let's do a relationship measurement. You can look at it from this perspective too. Maxilla is too narrow to the mandible. 54, 54, 5 millimeter discrepancy. Not a huge discrepancy, but in a full crossbite. He's in a full crossbite because his teeth are where they're supposed to be. Okay. Let's compare that to a patient like this. Okay. This patient is close to a crossbite, but not in a full crossbite. I'm sorry, the photos are a little bit blurry. On the left side, she's close to it, and she has no crowding. She has very, very little crowding. If anything, she had a little extra space in the upper. But if you look at the inclinations of her teeth and you look at the maxilla to mandible relationship, it's narrow. And you can confirm that on a CBCT. Look, nothing about her x-ray would give me pause per se. I mean, these teeth will come in normally, more than likely, if we don't expand now. But if I look to maxilla to mandible, her discrepancy is actually half a millimeter less than the kid I just showed you before. In my mind, these are the same patient. They're the exact same patient. One of them, every orthodontist in the country would treat. The other one may be put on recall for 6 months. They're the same patient in my book. They need the same treatment plan in my book. And interestingly enough, if you start comparing them in terms of airway, in a second, I'll show you that. The difference between these two patients is it's the inclination of the lower posterior teeth. Okay. The patient on the right side had lingually inclined lower molars, and so she didn't have a crossbite, but the one on the left had more upright teeth. He had a huge crossbite, but they're the same patient. And these issues happen all of the time. The other thing about this is that the patient on the left with the crossbite, he, at least from what I could gather from him and from his parents, didn't really have any issues with sleeping, snoring, any of those concerns. Now, he did have a bit of a tongue tie. However, the patient with no crossbite had far more of those symptoms. She didn't sleep well and she was snoring. She had some enlarged adenoids. And look at the difference in the palatal depth, the vertical distance of her palate, how vertically it's developed. I find that the vertical difference of the maxilla is the key to finding the airway patients as well. Okay. Again, related to the posterior inclinations, I'm going to zoom through this real quick. Their intermolar widths are big. Again, that doesn't matter to me. This patient on the left, 39 and a half. The other one was 41. All right. That's not what's important here. It's the maxilla to mandible relationship, the bony relationship, which is the skeletal relationship, which controls primarily, and we're talking about opening up airways. I mean, yes, inclining teeth and proclining teeth and expanding dentally, that certainly can help your tongue in tongue position and stuff like that. But changing the bony relationship of your maxilla makes a tremendous difference. Okay. They have the same problem, almost the exact same numbers, to be quite honest, just different teeth. Okay, so don't treat you treat skeletal problems with skeletal solutions, dental problems with dental solutions. Okay, that's the biggest difference. Now he had he had a bit of a tongue tie. You could see it on the pictures, and he had some mild speech delays, which we talked about and got him in the right hands for that. Didn't have any issues with the sleeping, snoring stuff though. I couldn't get anything out of them in that aspect. But of course, I would still do an expander. This patient though, the other patient. Tonsils were grade 3. Her adenoids were enlarged on the CBCT. She had a little bit of, I don't know if you saw the previous image, she had a little bit of a nasal septal deviation to the left. The sinus was super congested on the CBCT. She's had chronic sinus issues for a long time and a pretty significant tongue tie. Right? So, these are the same patients. They're the same patients. All right. Oh, there it was. I'm sorry. The deviated septum, sinus congestion, enlarged adenoids. The depths of the palate, though, were different. That was also very noticeable to me. From occlusal plane to palatal vault, about a 6 millimeter difference, 6.5 millimeter difference. Okay, and I'm going to show you one last patient, and then I'll quit so as not to occupy your day. I want to show a patient of that I've now inherited, and a patient for whom, unfortunately, I think treatment was failed, and you can see the results. Okay, just so that you're all clear on kind of how prominent this can become. All right, now this patient was seen for the first time in 2013. All right. Again, you can say there's no crossbites, but if you just look at the shape of the maxillary arch, the lingual inclination of those lower posterior teeth, the position of the mucogenital junctions, he has a very large transverse issue. Okay, now this patient had come, another thing that you can look for, if they come to you already having had adenoids and tonsils out, I would be willing to bet you 9 times out of 10 that they're going to have a maxilla which is too narrow. And in fact, many times if I have a ENT which is being more conservative with adenoids and tonsils, I can expand first, and a lot of times those symptoms will go away, or the grades of the tonsils will change from 3 to 2, or 2 to 1, or 3 to 1. Because again, the maxilla control, where the soft tissue is attached to the hard tissue, it controls a lot of things. You can see the tongue tie on there as well. All right. Now, we had tried, and I say we as in our practice, I hate to put my parents on blast, but I've had the benefit, honestly, of inheriting a lot of patients of theirs. And so I've been able to see patients who have been out of treatment for 10, 15 years, and I can see some of the patients that relapse. And again, they don't all relapse. Like my parents were tremendous orthodontists, but I always preface that. But they tried an expander. They tried a quad helix. I was trained with the quad helix in residency. I don't use them anymore because I found them, I have been unable to get them to expand properly. Okay. So, this is what this looks like. If you look at this number here, this is the vertical measurement of SNMP, so Sella-Nasion-mandibular plane. The bigger that number, the more vertical the mandible is. And you can see how narrow the airway is already, how low that airway is. Now, adenoids, tonsils have been cleared out, or adenoids have been cleared out, right? But here he is in 2016. You're starting to see some mentalis strain. The face is elongating. Okay, it's just 3 years later, right? This was after expansion, but the expansion I don't think did what we thought it did. Maybe it moved the teeth, but that's still a very narrow maxilla to the mandible. Okay. This patient basically is mouth breathing this whole time. I mean, you can harp on him about brushing all you want, and his brushing was not great, but also mouth breathing makes it look 10 times worse. Okay. And he's definitely mouth breathing. This number was 31. It's gone up to now 34. So it's increasing. Okay. His vertical relationship is increasing. 2019, where we attempted treatment and we failed. Obviously because we did treat the crux of the problem. The lower face is extremely elongated now. He's really having a hard time sealing his lips together. And just look at look how narrow that maxilla looks from the front. And look how severe and obvious now the transverse problem was. Okay. And how horrible his hygiene and brushing and mouth breathing have been. Okay. Turns out this patient had a deviated septum, of course, and on top of that, an extremely narrow maxilla. He's never been able to breathe through his nose his whole life. I saw him for the first time in 2022. He, despite all of that, I think he's like 6'8", and he's a collegiate volleyball player. So we have a MARPE planned for the summer. We've been able to start treatment because he's on a college scholarship and hasn't been able to do that. But look how that has altered his face from where he started to where he is now, and how severe the transverse was. So this is, I believe, in my opinion, if this patient had been properly expanded, the maxilla had been corrected to the proper dimension, there's just no way he would look like this. And so this is the effect of a narrow maxilla on the occlusion. So we need to treat these problems early. We need to be a little bit more aware of them. This is a 9 mm discrepancy. It's big. Okay. And we need to, but I think we also need to be able to delineate and diagnose very, very well. Okay. One of my other concerns that any newer topic like airway and stuff, there's going to be obviously a lot of things that we're still trying to figure out. But I was looking for something objective and quantifiable that we could use. And a CBCT is an objectable, quantifiable, and repeatable metric with a stable, identifiable landmark that we can use over time to justify the need for expansion. And those patients will be airway patients. It's just going to happen because that's all part of the same equation. And if it's not, and if I have a patient who has, issues that where the maxilla is not a width problem, it could be a front to back, and it could be an anterior posterior problem, or something that ENT may want to look at. There's lots of other ways to approach it. So my whole impetus on this was just to really try to dig down and find something that's a little bit more unique and definable. I want to make sure that we have something as orthodontists that we can use to bridge that gap between where we are and where we need to be. And really, I don't think that bridge is nearly as long as we think it is. I really don't. This patient had two sisters, both of whom have a very normal skeletal pattern with no airway problems. And you can see the very large difference that chronic mouth breathing over a period of, his whole life basically has made. Right. And so now the treatment plan is, of course, much, much different. Okay. So just to wrap up, we have to, the transverse is the first thing I think of. We have to evaluate it accordingly and properly. And a CBCT in my mind is just a no-brainer. I think for those who aren't using it, who are maybe justifying not using it, I think if we used a better analysis, like I'm trying to show here, I think we'd use it a lot more. Skeletal relationships are far more important than dental relationships. I look at the jaws are the first thing I look at. I don't even look at the teeth at the beginning. I look at the mucogenital junctions in the mouth intraorally, and then I look at the teeth after that, because we can all move teeth. Anybody can move teeth. You can move teeth with braces. You can move teeth with Invisalign, all sorts of expanders, dental tipping. But if you want to get sutural separation and move you need to expand the maxilla, make the jaw physically larger. Ideally and early for airway. Don't let patients like those ones who, develop those vertical patterns if you can avoid it. Make sure they can nasal breathe, and expansion is a huge part of that. They're directly related. So anytime a patient comes to you with a litany of airway problems, you can do the CBCT measurement that I was talking about, and 9 times out of 10, you're going to find that these patients have a maxillary transverse deficiency, all of which are correlated things like orthodontics that we deal with all the time, like severe crowding and palatal and impacted canines. All of those problems tend to go away when you expand. It's amazing how that's what McNamara always talked about. All these problems that we deal with, like impacted canines and bad occlusions, when you expand, they're just a lot easier. And now that I'm starting to see a lot of these phase twos, which I was expanded 5, 6 years ago, they're just don't have a lot to do, which I'm fine with. I'd much rather, it's nice to be easy. Got to think airway positive and consider all your options. Work with a team, ENT and oral surgeon. Adults have a lot of airway problems as well. It's not just kids. Airway problems are everywhere. And, in fact, where airway comes from, I would say, is from adults. People were trying to figure out, why is it that some patients just seem to grind the heck out of their teeth and destroy everything, and others don't. Why is that? And airway is the best explanation that I've ever heard for it. It makes the most sense, and I think has been borne out by a lot of the research. And of course, if you look back at those patients when they're younger, those problems didn't just start when they're in their 30s. It also makes the conversations you have more impactful. So especially for that patient that I showed you at the end, right? I mean, who needs a MARPE, how do you talk about, I used to have to talk about palatal expansion on adults like that you'd have to be like, well, we got to expand these teeth because these teeth are supposed to fit over here. And if you don't, then the teeth could chip or break, or you could have recession. By the way, have you ever had an issue breathing through your nose? I'm like, oh yeah, I can never breathe through my nose. Oh, well, that makes more sense because all of this is related. And so you can get patients to a better place so that they can understand what they're dealing with. Same thing for kids and parents. I rarely have any pushback on recommending expansion because I can have a better conversation. It's not just me describing it. It's like, well, you've had all these issues. These things are all related, teeth and airway. It makes a lot of sense. So with that, I will wrap up. And again, maxilla to mandible, that is the relationship. Your mandibular width becomes your guide, and your maxilla is the thing that you can broaden to expand to that. So with that, I will stop sharing. But thank you guys. Sorry for.
Please don't stop.
No.
This was one of the best orthodontic presentations we have ever had.
Oh, good.
I am in awe. I want to go to Atlanta right now.
Oh.
Wait, I'll be there this weekend, but I won't be there.
Yeah.
Oh
Well, thank you.
gosh, I love how you measured and you compared the relationship of the mandible and the maxilla. I feel like that makes a lot more sense to explain to people why some patients even.
Let me ask you this, and this was my theory. Has been my theory on that, and I want you to, because you're probably more knowledgeable in the myo space, but like, let's just say your tongue was completely tethered, horrible tongue tie, completely tethered to your mandible. Does it not make sense that the mandible would be as wide as it needs to be to accommodate the tongue? Because if it's just like stuck,
It's true.
it's got to be, but your maxilla won't be.
Mm-hmm.
And we're as orthodontists, we're used to using the mandible as a reference point for the maxilla all the time. Like in cephs, when people were talking about extraction treatment, it was always the lower incisor is your reference point. It's always the lower arch because you can't change it. But I just don't think we've been taught on how to use CBCT. Anyway, I'm hoping that if we can popularize this measurement tool or this analysis more, then it really won't. It will make it a much easier conversation to have, because you can get people to do expansion if they don't even want to think about airway, which is silly, but they'll get it once they start doing it. I think that's my hope, at least. That's it. So anyways, I'm glad to hear you enjoyed it.
I love it. For the intermolar width, I'm also not a huge fan of measuring clinically as much. So what I do, I usually use a caliper, and I tell all my patients whenever you put this in the palate, don't touch the teeth. I want you to close a little bit more, go a little bit higher, and touch the palate. You're actually going to poke yourself with these on the palate because I want to see how much room the tongue has, and not necessarily how wide the teeth are, how far apart 3 and 14 are, because yes, you're going to get skewed measurements. So even on the CBCT, I had a meeting with a TrueView and Beam Readers. They're two companies that are actually designing protocols. I actually just finished designing the protocols for airway circle. So if you guys call these companies and say, we want the airway circle protocol, it's going to be an option. Besides the basic things for the CBCT readings that they're doing, they're going to have all these extra images that we think they're very beneficial for anybody looking at airway, myofunctional therapy, dentists, and orthodontists. So anyways, I was telling them wherever they were measuring, they usually measure the CEJ. I was like, hey, can you go like a little tiny bit more? I want you to make sure that you're on the palate bone. So
the reason I use the buckle, so originally that analysis, I took it out of the lecture because I didn't know if we'd have time, but that analysis originally was talking about periodontal tissue. So the rationale for using the buccal bone, the buccal cortex, is that if you make the maxilla broader, you can dentally expand the teeth further into the maxilla. But if you try to use let's just say you put on some braces at a heavy wire, you can translate those teeth outside of the maxilla, and it looks like you've done a good job making you've made the tongue space bigger stuff. Over time, though, those patients in their 20s, 30s, and 40s, they start exhibiting tons and tons of buccal recession because there was no bone there to begin with. So what I want to know in terms of just positioning teeth is, do I have enough room on the buccal to tip teeth that way or not? And if you make the palate bigger, the entire complex goes with it. And so that buccal bone is changing, wherever you want to measure it. But the buccal aspect is more useful for me because I can then see where I can then see where I need to move.
Exactly. Is there any hope for an adult who has recession, buccal recession?
Yes, there is. I mean, I think, I think there is. What causes recession a lot of the times is, people always would just say toothbrushing or whatever, but really it's function and occlusion. So those compensated discrepancies, quite frankly, when you look at those as adults, they're almost always exhibiting buccal recession especially on the lower posterior teeth, which are lingually inclined. As they're occluding, they're bending those teeth, and that buccal bone pulls away over time. It's like, I think someone described it like a fence post in the ground every time if you do this every night. But the component there underneath all of that is function. So if you have someone who doesn't grind their teeth at night at all, there's no reason for that bone to resorb like that. But someone who's functioning super heavily, it's an issue. So for those patients, I mean, grafting is one, but grafting typically will just delay. It's like it'll put a Band-Aid on the problem. SFOT or PAO, basically the corticotomies and grafting, but it doesn't build up new bone. But what you're trying to do really is prevent future recession. So for someone who wants to be super conservative, I mean, you can make a night guard, and that sometimes buys you some time. But when I do, that's where MARPEs come into play, and in the way you design the MARPEs, if you need to, because if that's the problem, those teeth are being inclined like this, then you can build a MARPE, and then once you secure it in the palate, you can cut all the appliance off the teeth, and then you're expanding only the bone, not even that. So there's no dental effects. And when I used to do SARPEs in residency and early in my career, where it was just a surgical expansion, typical, you end up getting a lot more buccal recession because along with moving the jaw, you move the teeth out of the bone. And then you just kind of have to pretty much manage it. But I think the MARPEs have definitely changed that equation. I think, and it depends on severity, but I've also seen the scenario that I see more often, honestly, is over constricted arches. So it's not just over expanded arches, it's over constricted arches. And I've seen a lot of, especially in extraction cases, I went back after I did this analysis, and I looked at a few of my older extraction cases that I did early in my career. And what I found was the when you extract, you move the posterior teeth, they move forward a little bit, and you actually end up resolving the transverse discrepancy by moving the teeth into a different part of the arch. If you go
Mhm.
back and look at the CBCT on a few of the patients that I had, um, I actually was extracting on maxillas that were a little too narrow. And if I had expanded them, I would have gotten the space that I needed to not do that. And I wouldn't say extractions are never indicated. I mean, they're just very, I just don't do them rare. If you get them on early enough, quite frankly, I don't see how you can't get there. I've had, mesial space loss. It's just the window is very small, in my opinion. It's not nearly as wide as we wanted it to be. And I think we were treating not treating the root cause. I think we're just treating the teeth because that's what we see. But the teeth
Mhm.
just the teeth are easy to treat if the bone's in the right spot, you
Can
know?
we put that in a billboard?
What's that?
Can we put that in a billboard somewhere
Yeah, sure.
all
Yeah.
over the country? My goodness, I have so many questions. Okay, so an adult who has recession and a constricted maxilla, there's still hope. Is it still safe for them to get maybe a MARPI and then have braces or Invisalign afterwards? What could possibly happen to that recession? Do you usually recommend having grafts done before, or can you move that? I'm not an orthodontist. Can you move the teeth in the dental velar bone after they're expanded in the MARPI? And I mean, the bone will never grow on the buccal again if there's.
Right. So I would say you it depends on in terms of the graft. So the answer is yes, and the way you would design your MARPI is to not touch the teeth, right? I would do that in conjunction with a periodontist. I have a few colleagues that I work with. If you're worried about the recession worsening, or if you have lingually inclined teeth with recession, typically in terms of uprighting those teeth, especially on the lower, you would do SFOT or PAO. So basically corticotomies, flaps, bone grafting, and uprighting. And then what you do is it's not that you gain bone back, but the cortical plate then is allowed to move with the teeth as
Yeah.
opposed to the teeth moving through the cortical plate. You can do that in the anterior or the posterior. So what I've seen most often is, Rick Robley's done a lot of this. He's a big surgical, he does a lot of cool stuff, a lot of cool stuff. Is Marpy on top with lower aligners and SFOT. So
Okay.
he's in broadening the cortical plate base basically for your lower arch. So the answer is yes. I mean, I think you always have to look out for that. But the reality of it is what I see most of, it's not just, I mean, a little recession, I hate to say, a little recession is not going to kill you. What causes teeth to fail is severe progressive untreated occlusion recession. So like someone who's who's functioning really heavily on a tooth, grinding a lot on these teeth, and the bony base just dissolves away eventually. I think I've seen periodontists keep very recessed teeth in the mouth without any problem. But I guess for me as an orthodontist, my always concern is like because we don't get to see our patients really after a lot when they're like 15, 16, they leave.
Mhm.
So I always wonder what my patients are going to look like when they're 30 or 40, because I see a lot of adults as well. I do a lot of restorative treatment, and I, if I, my, on expansion and stuff like that, if I get the teeth upright, at least I'm giving them the best shot. I won't guarantee they'll never have recession, but at least I'm giving them a better shot that they won't, and that they won't have as many dental issues down the road. So.
For what kind of a message can you send to dentists who are doing full cosmetic cases on patients who do not have a stable occlusion?
Yeah, so I think for dentists who are doing like full cases, full mouth cases and stuff, that's what we teach a lot at SPEAR is to have a diagnostic process. We have what originally was called the EFSB method, aesthetics, function, structure, biology, and then added to that was airway. So it's now airway, aesthetic, structure, function, biology. So in terms of comprehensive cases, the aesthetics, what Frank Spear always taught was the aesthetics drives the plan. But underneath that, you have the structure and the biology of the occlusion, and you have to get that to work in your favor. Airway is the component which controls a lot of the function. So if you have patients who have bad airway, they're the ones who you're going to have to rehabilitate. But the problem is, you do a full mouth rehab, not that I've done full mouth rehab, but if you've done that and it breaks down on you, I mean, that's a bad day. So what Jeff Rouse at SPEAR brought into it was, he's a prosthodontist by trade. He's not an orthodontist or a pediatric dentist or whatever. He's a prosthodontist, and you see prosthodontic failures are people who have these long-standing chronic problems of recession, chipping. It's recession, wearing of the teeth, and caries. Those are your three chronic long-term problems. And maybe not as much caries, but the other two are mostly just if someone's clenching and grinding their teeth or not, because you use your teeth sparingly during the day unless you're eating or swallowing.
Mm-hmm.
You do it a lot at night, which you can't control. So if you have an unstable base, you have to build from the ground up, and airway is the base. I mean, that's it. That's where airway got moved to the top of that pyramid. It's airway EFSB. So if the patient's airway is a mess, if you don't control that, you can do as much dentistry as you want, and people do, and then you can watch it fail. And that's what people are missing a lot of times. So his course is great for it's designed for restorative dentists,
Mm-hmm.
because they see these problems. And now that
Mm-hmm.
I'm in that world, I see those problems
Mm-hmm.
a lot.
Amazing. Couple more questions before we go, if you have time. A child who is a class two, but they're bimaxillary retruded. All my orthodontist friends always ask me, Renata, if I expand them and they move forward more, what am I going to do with the mandible? I always say, I don't know, because I'm not an orthodontist, but I
Yeah.
see people do different types of treatments. I know
Yeah.
that, myofunctional therapy, mine, to bring the mandible forward, I need to make sure that I can bring the tongue forward, up and forward. So if they have a tongue tie, if they just have low tongue posture, nasal obstruction, I know that I can, do what
Yeah.
I do to make sure that the tongue can move up and forward. But as an orthodontist, what are your options?
Well, my thinking on class twos has changed a little bit. I mean, first of all, I have seen many patients with expansion in class twos self-correct or improve their class two relationship a lot. And McNamara talked about that for years. And when you start doing it, you start seeing more of it. Not everybody. Um, the other part of it is there's also a world that I'm not as deep into, but in the TMJ world, there's a lot of thinking about where those discs on those class two patients are
Mhm.
being in the wrong spot. The reality of it is most class twos will get better with expansion. And a lot of times the class twos are not as severely class two. If your arch is very narrow, it pushes your front teeth out to a lot of overjet. When you expand, it brings the front teeth back to less overjet, and the molars will come forward. So if I can get someone from a full class two to a half step class two, then I have a lot more options down the road for me. Now, if someone is still a full class two, then you're kind of hoping on a Herbst to bail you out of it. I had a Herbst appliance when I was younger. I snore a lot, but I have an oral appliance I wear every night to stop me from snoring, and my sleep scores are great. So, it's tough. But I would say there's a different take on that with the TMD people who would want to look at an MRI about where the joints are. What I have found and what McNamara talked about is if you expand those patients, it does unlock the mandible to a certain degree. They come forward in your class two lessons over time. Also, there's some thinking about, if someone is mouth breathing, where they put their tongue and how that changes your mandibular position. I suspect, just like most everything, this is probably part and parcel of the same thing. I think many airway patients have related joint conditions as well. The discs are in the wrong spot. And I feel like a maxilla that's too narrow almost traps your mandible from being allowed to come forward. And if you don't resolve it early enough, those patients can develop, or I'm conjecturing mostly, but can develop more TMD. A lot of patients I've seen with TMD issues have narrow maxillas, and the airway problem is what exacerbates the function on all of that and makes it worse. So they're not easy to treat. No one's eager to
Mhm.
treat those patients, but for kids at least, I do the same measurements that I did before.
Mhm.
It's not a whole lot different, and I expand to where I need them to be, and I've found a lot of good results with that early.
How early do you treat? What's the youngest?
The youngest that patient I've treated for with expansion was probably four, I believe, 4 to 4.5, and it was a face mask expansion case. So, class 3 patient with airway problems, maxilla was, yay big. And the reality of it, I think for me, that's probably where, just in terms of my practice, where I set my bar. I just, because of the appliances that I'm used to using that are fixed,
Mhm.
traditional appliances, and the patient age and tolerance of that, that's where I would stop myself, I suppose. But the reality of it is, I mean, I see patient. My youngest is 4. My oldest is youngest patient is 4. My oldest is 87. So I
Amazing.
treat patients of all shapes and sizes. I mean, mostly kids because of what I do, but a ton of adults as well.
And what is the youngest one you've done a MARPE and the oldest one you've done a MARPE on?
Youngest I've done a Marpy was she was I think 12 and a half. But she was one I expand so she was the third sibling.
Mm-hmm.
Both brothers relapsed on me during expansion, and so she came in and she relapsed again. So I told mom, I said, "Look, I don't normally do this because at 12 I feel like I can normal." I was like, "I'm just tired of this working." And I on my cousin who's also 12, doing just a 2 tad Marpy, like a small little baby one.
Mm-hmm.
And the oldest patient I had at a Marpy is 65. 62,
Amazing.
maybe 60, maybe something like that. Early 60s. Full restorative case with it's on Spear Talk if anyone's on Spear, but it's a Marpy with lots of restorative components, SFOT, Marpy, veneers. Like it was a fun case.
Any other options for the herbs appliance? I feel like most of my patients that get the herbs eventually end up with a very flat maxilla.
Well, that's where you have a there's a headgear effect to the Herbst appliance, to all of class 2 correctors, unfortunately. I mean, to be honest with you, I mean, my opinion on well, this is a little bit unorthodox, but I'm not as I'm not as torn up by class 2 patients long term. I think the question I would say that I'm starting to kind of work out is I would want to know where those patients' discs were in their joint. I'd be willing to bet,
Mhm.
and what I've seen from people, and I can't say I don't do this, but if you do MRIs in those patients, those joints are not in the right spot. And some patients with herpes work out great, others don't. So
Mhm.
the ones you that work out, you look like a genius. And what I'm thinking is happening is maybe we're recapturing those discs because we're pushing the man, and then the mandible grows and we look good. And then the ones that aren't in place, we never get them, and then they look okay, and then they click.
Mhm.
So I don't have a great, I don't have anything that's super different than that. But I do a lot. I will also say this: I do a lot of surgery
Mhm.
with an oral surgeon. And if I have borderline herpes cases, which are a bit of a stretch, I have no problem just saying, look, you'd better off either staying here or doing surgery. And airway's the kicker to get them over the hump. If I had a larger mandible, I probably wouldn't have to wear my snoring appliance that I have at night.
Mhm. All right,
Um,
last question.
yeah.
At what point during your treatment do you recommend myofunctional therapy?
As soon as I can, as soon as we need it. I mean, I think a lot of times it kind of depends on the tongue tie, but most of the time, if I have a patient with a tongue tie or bad tongue posture, all those kind of things, I'll refer them and then expand, and then they'll be seeing them during and after. It's what we've mostly worked out. And I've also had some adults who need it too. Um, I've had some patients who go through with it. I've had others who kind of balk at it. I will
Mhm.
say if we change the relationship, it tends to be a lot more stable. But
Yeah.
is whenever we can. I've worked with some good people in the area that have been very kind to me. So
Awesome.
yeah,
All right. Well, thank you so much. I'm so sorry I kept you longer. I wanted
that's
to,
okay.
I have so many questions, and we're actually going to put all these questions in our podcast. It's called Beauty of Breathing. So if you guys are not following us on your favorite podcast platform, please do so. Thank you so much, Dr. Tyler. This
Thank
has
you.
been absolutely
Appreciate it.
wonderful. You guys, I'm going to put all his information in the Airway Circle Professionals page if you'd like to follow him. Have a wonderful
All
weekend.
right.
Thank you so much.
Thanks so much. Bye bye.
All right. Bye bye.